Hello everyone, my name is Lauren Heinecke and I'm an assistant professor of pharmacotherapy at the University of Maryland School of Pharmacy. And today it's my pleasure to be with you talking about part 7 of our Antibiotics from Head to Toe series. Specifically today we're going to be focusing on cellulitis. So our objectives for our talk today are, by the end of our time together, you should be able to discuss organisms that are most commonly seen in patients who are infected with cellulitis. We're going to talk about signs and symptoms of patients who present with cellulitis, and then finally we're going to talk about how to appropriately select empiric antibiotic therapy for a patient who's presenting with cellulitis. So we'll start out talking about a little bit in terms of the epidemiology. So how important is this disease state? So in general, when we talk about cellulitis, it's lumped into a broader category of skin and soft tissue infections, or SSTIs. So we'll talk about all of the different types of infections that are included in this. But cellulitis and SSTIs, it's very difficult to come up with an exact number of cases and exactly what the epidemiology is for this disease state, because many of the infections are mild and many are treated in the community. So very difficult to get an exact epidemiology. So some of the numbers that I've seen listed, there was a study that looked at physician office visits, so outpatient, which would be mild treatment or mild infections. So this was taking a look at physician office visits between 1993 and 2005. And skin and soft tissue infections were diagnosed in 0.8% of their office visits, which corresponds to about 82 million diagnoses of skin and soft tissue infections in this particular observational study. There also was a report that came out in 2007 from the Agency of Healthcare Research and Quality, or AHRQ, which is much easier for me to say. And in this particular study, they found that it was responsible for over 600,000 hospitalizations. So it's very difficult to get exact numbers, but it affects a significantly large number of people and is an important disease state for us to be aware of. As I mentioned, one of the reasons that it's difficult to determine the exact epidemiology is that most of the cases are mild, but it is important to know that it can be life-threatening and we can see it be a cause of necrotizing fasciitis. I think the other important piece to point out is really we've seen an increase in community-acquired methicillin-resistant Staph aureus. And it's important to know that with community-acquired methicillin Staph aureus, actually has the ability, it's genetically different from hospital-acquired Staph aureus. And the way it's different genetically is it produces a toxin called Panton-Valentine leukocidin. And this toxin, or often called a cytotoxin, ultimately is responsible for leukocyte destruction and tissue necrosis. This frequently leads to purulent or production of pus, and just a more virulent strain, so leading to more severe infections. So a couple of things changing from an epidemiology standpoint that make, I think, this an important topic for us to talk about and to be aware of. So I've sort of delved into a little bit in terms of the etiology, talking about Staphylococcus aureus. And so this table really goes into all the different types of skin and soft tissue infections. So talking about the etiology and classification of different SSTIs. So the majority of SSTIs are actually caused by gram-positive organisms because they're present on the skin surface. And you'll notice that I'm going to have two different slides. This first slide deals with primary infections. We also have a slide that talks about secondary infections. So primary infections, as you'll see on the slide, usually involve areas of previously healthy skin and are caused by a single pathogen. On the other hand, secondary infections occur in areas of previously damaged skin and frequently are polymicrobial. So think about treating them a little bit differently. So we have a few different types of infections listed up there that cause primary infections. We have Erysipelas, which is something that you may or may not have heard of before, typically caused by group A strep. Impetigo is typically caused by Staph aureus as well as strep. It's frequently seen in small children. Frequently affects the nose, the nares. Lymphangitis is typically strep, occasionally staph. Cellulitis, which is where we're going to focus the majority of time, typically is caused by either strep or Staph aureus. Occasionally other gram-positive cocci, gram-negative bacilli, and or anaerobes can be involved, but that would be more rare, and we'll talk about some different risk factors that might result in causing some of those additional microbes to be present. And then finally, necrotizing fasciitis, which is really going to be our most severe type of skin and soft tissue infection. You can have type 1 and type 2. Type 1 is caused by anaerobes and facultative bacteria, whereas type 2 is usually caused by group A strep. So really we're going to be focusing on cellulitis, but because when we talk about cellulitis, it's frequently lumped into our skin and soft tissue infections or SSTIs, I thought it was pertinent just to go over a little bit of information relative to all these different types of infections, because you may hear other terminology related to them. So just taking our etiology a step further, I thought it was important to talk about cellulitis relative to anatomic site before we move on to talking about secondary infections. Essentially on this slide, what I have listed for you is the anatomic site or risk factor, the location of the cellulitis, and then how that determines the likely bacterial cause. So periorbital cellulitis is located periorbitally and typically is caused by Staph aureus, Strep pneumo, as well as group A strep. We now have Strep pneumo in the mix as well. Buccal cellulitis, which would be located in the cheek, we're looking at the likely bacterial cause for that being H. influenza. Cellulitis that's complicated by a body piercing. So this could be in any location somebody is able to get a piercing in. Specifically, I have listed up their ear, nose, and an umbilicus. This is going to be our typical cellulitis bacteria, our Staph aureus, and our group A strep. After a saphenous vein harvest for a cabbage, going to again be group A or non-group A beta hemolytic strep as the most common. A post-op wound infection, specifically the locations would be the abdomen, chest, and hip, are going to be group A strep. And in patients who have a history of intravenous drug use, which can involve the extremities and the neck, typically we're going to see Staph aureus, but we could also see group A, C, F, and G strep as well. So again, relatively common to see gram-positive organisms, typically Staph aureus, and group A strep, but there are some circumstances where you may see some other bacteria that could be involved. So there's a lot in terms of knowing the specific location that really helps in terms of determining the etiology. So before we move on and just briefly talk about secondary infections, and so you have a general understanding of what types of infections those are and the bacteria associated with them, I wanted to just present a slide that compares cellulitis and erysipelas. So erysipelas, the lesions are raised above the level of surrounding skin. This is not seen in cellulitis. You don't have a raised lesion. So the raised lesion is going to make you think of erysipelas. There's also a clear line of demarcation between the involved and uninvolved tissue if you've got someone with erysipelas. I think the other really interesting thing about erysipelas is there's an intense red color and burning pain associated with this type of skin infection. And this led to the common name of St. Anthony's fire associated with erysipelas, if you've ever heard of that term before. And the lower extremities are the most common site. I think really the two things that differentiate erysipelas from cellulitis are really that raised nature of the infection, as well as the clear line of demarcation and that intense red color and burning. Cellulitis does extend deeper into the subcutaneous tissue. And I think the other big thing to point out that's different between these two is if you go back to, if you've printed out the slides, the etiology slide, erysipelas is primarily caused by group A strep, whereas cellulitis, we're thinking additionally now about Staphylococcus aureus. So if you can differentiate between the two, it helps you in terms of determining whether you just need strep coverage or whether you need to maybe consider having some MRSA coverage. Since we've talked about there is this evolving profile in terms of there being more methicillin-resistant Staph aureus out there causing cellulitis. And we'll talk about a little bit of the evolving epidemiology, or actually etiology, in just a few slides, and a pretty recent publication that has come out that delves into that specific question. So I did want to talk about this specifically in my practice. I haven't ever seen erysipelas diagnosed, and I think one of the problems is I think erysipelas is probably commonly called cellulitis. But I think it's important for us to think about and really differentiate between someone who has erysipelas and cellulitis, again, because it does change the pathogen that we're thinking about covering. So I wanted to make you all aware of that as part of our talk here today. So wrapping up our etiology section, this is a slide going over secondary infections. And I mentioned before, secondary infections involve areas of previously damaged skin, and these are going to be polymicrobial infections. So some frequent types of secondary infections you might see are diabetic foot infections, as well as pressure sores, bite wounds, and then specifically they divide out the way you think about bite wounds depending on the type of bite that it is. So animal versus human, and then the last one is burn wounds. So we're not going to talk about all the specific bacteria, but I do have that information presented up there for you in case that would come up. So certainly, probably 50 minutes is not enough time to go through all of the different types of secondary infections and how to think about treating those. As I mentioned, we're really going to focus on cellulitis, but we wanted to give everybody a general overview of all the different types of skin and soft tissue infections that tend to be sort of lumped together when we think about this disease state. So before we delve further into the pathophysiology and the clinical presentation, I wanted to go over a little bit about classifications. Classification systems, really the primary versus secondary is one type of way to classify your infection, and that helps to think about the type of organism that you most likely need to think about treating. And there's also sort of this generic complicated versus uncomplicated definition that you'll see in the literature, and the way it's essentially defined is that a complicated infection involves deeper skin structures such as the fascia or muscle layers. It's also defined as requiring significant surgical intervention, or it occurs in immunocompromised patients. But it doesn't really delve into exactly what you do with that. Essentially, you could extrapolate saying a complicated infection would need IV therapy, potentially a longer duration of therapy, depending on how well you're able to surgically control the infection. But not a lot in terms of exactly how that contributes to how we're going to treat the infection. So there's actually a newer classification system that really divides SSTIs into 4 classes based on severity of signs and symptoms, as well as the presence and stability of comorbidities. And it was really developed to aid clinicians in determining whether the patient needed to be admitted and to aid in treatment decisions. So is it going to be oral therapy or IV therapy? So how do you determine how you're going to treat the patient? And so essentially the way this table is set up is that in your far left-hand column, you have the different classes, class 1, 2, 3, and 4. The middle column tells you about the patient population, and then the far right-hand column tells you about the treatment. So in class 1, these are afebrile and otherwise healthy patients who would be able to be treated outpatient with either topical or oral therapy. Class 2 then is slightly more, probably mild to moderate. They're going to be febrile and ill-appearing, but no unstable comorbidities. Again, these could be either outpatient or short-term hospital stay, and could really go with either IV or oral therapy. Class 3 now is really more of a moderate infection who's toxic appearing, unstable comorbidities, or has a limb-threatening infection. These patients are going to be inpatient, and they're going to be started out on intravenous therapy. Now, that's not to say that you couldn't transition them to oral therapy before they go home, which is the case with essentially all of the SSTI infections I've been involved with treating on the general internal medicine floor. And then class 4, these are going to be patients who have really more of a severe infection. They have sepsis syndrome or other life-threatening infection. They're also going to be treated inpatient with IV therapy. So the treatment decision really is to determine where they're going to be admitted to and what your initial therapy should be. Certainly, once you've got the infection under control and the patient stabilized, transitioning to oral therapy would definitely be something you'd want to consider doing. So I think the next big thing to talk about is the pathophysiology. Why do patients get cellulitis or skin and soft tissue infections? And interestingly enough, the skin and the subcutaneous tissues are actually highly resistant to infection. The reasons for this is that the surface of the skin is relatively dry, and the pH of the skin and subcutaneous tissues are about 5.6 more acidic than what our microbes like in terms of being able to grow. So it's very resistant because it just doesn't provide an environment that's really conducive to the growth of microbes. Typically, what happens is that there's a disruption of the normal host defenses when you see the development of cellulitis or an SSTI. And so this could be secondary to comorbidities such as diabetes, or it could be a result of a puncture or an abrasion that essentially disrupts the normal host surface and essentially then allows for the development of an infection. Ultimately, then the nature and the severity are really dependent on the microorganism as well as the place that the infection is occurring. And we've talked about really how to classify the infection based on severity in our previous couple of slides. How do these patients typically present? Well, typically we would see maybe previous trauma or underlying skin lesion. We'd really be looking for that. We've just talked about the skin and subcutaneous tissue really are highly resistant to the development of infection. So we're looking for what's the source? How did the bacteria really gain access and really have been able to outsmart the host defenses? Typically what we see is local tenderness, pain, and erythema. So that's really our first clue. It's typically, in the infections that I've seen, they've complained about a very specific area that's red and painful and has local tenderness. Patients may also complain about some more constitutional types of symptoms, including malaise as well as fever and chills. And then the infected area, as I've already sort of alluded to, is often red, hot, and swollen. And so the presence of that specific area that's red, hot, swollen, is tender, those are really the big clues that the patient has, a cellulitis that's going on. And so ultimately, in terms of talking about diagnosis, really it's based on clinical suspicion in the patient presentation. So we don't really get cultures, and the reason for this is that there's a very low sensitivity associated with this. And there's only a pathogen that's identified in about 30% of patients. We've already talked about the common etiologies primarily are gram-positive in nature, and then depending on your location or other risk factors, as we've talked about earlier, you may consider covering for other bacteria, but predominantly we're talking about an infection that's typically caused by strep or staph. In addition, we may have some laboratory findings. There may be an elevated white blood cell count on CBC, but ultimately it's really based on our clinical presentation and that local area that's red and tender and painful. So before we get into talking about treatment, I had alluded to the fact that maybe we have a change in terms of what we're seeing from an organism perspective. Before we move into talking about the treatment, one of the things I wanted to spend a little bit more time on, because I think this is probably one of the more controversial topics or treatment decisions right now, is which is the most commonly isolated organism? Is it strep? Is it MSSA? Or is it MRSA? Which one should we be most concerned about? And I've already told you on the last slide, from a diagnosis perspective, really we aren't frequently able to isolate an organism. So this is a difficult question to answer because our cultures have this low sensitivity, and only about a third of the time do we identify a pathogen. So we don't get cultures frequently. So there was some data published between 1995 and 2005 that really indicated an increase in skin and soft tissue infections caused by community-acquired MRSA. But there's conflicting data about our current community-acquired MRSA status, and I think probably a lot of it's based on geography in your particular area, as so many other things related to antibiotics and the trends that we see related to microbes really are geographic in nature. So I did want to just go quickly through this study that was published in 2013 in the British Medical Journal, Infectious Disease. And so specifically, they were looking to identify the incidence, microbiology, and patient characteristics in skin and soft tissue infections in the U.S. population. Specifically, they were using an electronic database to describe these characteristics in a group of members in Northern California in an integrated health plan. So it is a very specific group from Kaiser Permanente that were included in this study. So they looked at anybody who was diagnosed with a skin and soft tissue infection between 2009 and 2011. So on this first slide, it's really the demographic information. So they had almost 500,000 patients that they included, so a really big number. The type of SSTI is listed up there for you. Basically, 63% of those patients included had cellulitis and an abscess. So the majority of patients did have cellulitis that were included. About half of the patients were female, half were male. In terms of the age, the mean age was 40 years of age, but the majority of the patients, so more than 50%, were over the age of 50, 18 to 50. So we're looking at a relatively older population, but we do have a pretty decent number of patients in the middle of that demographic as well. Then in terms of the race, 50% of the patients included were Caucasian. So always important just to keep in mind the population that they're looking at. So then from there, essentially what they did is they took a look at the microbiology testing. So of the almost 500,000 patients that they had included, about a fifth of them, or about 100,000, had some sort of microbiologic testing. And so you can see that the majority of the specimen types are listed under other. And just so you know what other could include, it could include tissue or body fluid, other miscellaneous bacterial specimens, which could include an abscess, pustules, boils. So the culture locations were really all over the board. About 14% of them were blood cultures. In terms of what they found from a microbiology standpoint, which is what you see on the bottom part of that graphic, 37% of the organisms isolated were MRSA, 44% were MSSA, 10% were beta hemolytic strep, less than 1% were other strep, and then you can see there were some gram-negative bacteria also identified in about 14% of the specimens. So what I think is interesting about this publication is that the majority of their culture-positive skin and soft tissue infections actually were caused by staph, and almost half of them were caused by methicillin-resistant Staph aureus. So in thinking about the trend and which is the most commonly isolated organism, staph, at least in this patient population, was what was seen most frequently. I think we have to be very careful in terms of how we extrapolate these results, because I think, questions you think about, is there something different about this patient population in terms of the specific patients that they were getting cultures on. I've already mentioned that patients who are infected with community-acquired MRSA species typically have a more virulent pathogen. They're typically going to have more purulent, so pus forming in terms of the cellulitis itself. So we may be more apt to culture something like that if there's an abscess or something like that, which might be more common with community-acquired MRSA skin and soft tissue infections. So I wanted to show you this data because I think there is a lot of question about, do we need to cover MRSA? Is it okay just to cover strep? And I think there's going to be, a lot of discussion about that in terms of exactly how to proceed. I think frequently we start off maybe covering strep and MSSA, and then if the patient doesn't resolve with less broad antimicrobial, we think about broadening to cover maybe a methicillin-resistant Staph aureus. So just wanted to touch on that before we get into talking about treatment specifically for skin and soft tissue infections, really specifically focusing on cellulitis itself. So now that we've had our discussion about epidemiology under our belt, let's talk about the treatment of skin and soft tissue infections. So I have two slides for you. One is for MSSA skin and soft tissue infections. The second one is MRSA skin and soft tissue infections. And I know we've talked a lot about strep being a very common bug in skin and soft tissue infections and cellulitis. And so from there we'll talk about which antibiotics we get strep coverage with and which ones don't. You'll see that there's a lot of similarities in our staph and our strep coverage. So the way I have them listed out for you is the antibiotic, the dose, and whether they're administered intravenously or orally. I also have the pediatric dose listed for you as well. So you'll notice up there that we've got several intravenous options, nafcillin or oxacillin, cefazolin, clindamycin. Those are really our IV options. Our oral options include clindamycin, dicloxacillin, Keflex or Cephalexin, doxycycline, and Bactrim. And some of those we're also going to get MRSA coverage with as well. So we'll talk about which ones we get our MRSA coverage with in just a second. I think some of the things to point out are the frequency with which things are dosed. So frequently for somebody who has a severe enough infection that they get admitted to the hospital, we'll start with intravenous therapy, and then after 24 to 48 hours it looks like it's starting to get better and we'll go ahead and switch them over to oral therapy. And frequently when we send people home, we try to send them home with something that's a little bit less frequently, because taking things 4 times a day is much more difficult than taking something twice a day. Frequently the people that I see come into the hospital have already gotten a course of Keflex. So at that point, we might be thinking about it being MRSA and needing something that covers a methicillin-resistant Staphylococcus aureus. But many of our regimens that treat methicillin-sensitive Staph aureus certainly are 4 times a day, and that is difficult for people to do. But it's important to discuss the importance of continuing those medications and taking them as directed because of the potential development for resistance. So those are the regimens that are recommended in CID, and we'll talk about some updates to those in just a few slides. So the treatment options you have for methicillin-resistant Staph aureus now are intravenous options. The slide is set up the same in terms of the antibiotics, the adult dose, and then the pediatric dose are going to be vancomycin, linezolid, clindamycin, and daptomycin in terms of our IV formulations that we have available. And I think probably most people see clindamycin or vancomycin used probably first line, and then linezolid and daptomycin are saved for treatment failures, or potentially if somebody developed a VRE, vancomycin-resistant enterococcal infection. And then our oral options, when usually if somebody is sick enough to come into the hospital, we'll see them started out with 24 to 48 hours of an intravenous product, and then at that point in time, we're looking to switch them over and hopefully send them home, and generally our choices are either doxycycline or Bactrim. So I will just throw this in here since we talked about oral vancomycin in our diarrhea lecture in terms of talking about treatment of Clostridium difficile diarrhea. Remember, we do have an oral vancomycin product available, but it's not absorbed, so we can't use oral vancomycin for skin and soft tissue infections. So those essentially are your treatment options up there. And a lot of times we reserve linezolid and daptomycin for treatment failures, again, due to expense and the potential to expose people to broader agents that could induce resistance. So now it's time for the first of our 2 poll questions, and I thought I'd give us a little case to practice with. So this is the case of PR, who's a 35-year-old male, and he presents to his primary care physician with a chief complaint of a red, swollen, and painful arm for about 3 days. He does not have any significant past medical history. However, on physical exam, he's found to have a temperature of 39 degrees Celsius, but he doesn't have any abscess. So I think the next important question, something that there's some discussion about, is which agents give us strep coverage. So the question is, do I still get strep coverage? And on this slide, I have essentially the antibiotic listed for you on the left-hand slide, and all of the antibiotics that we went over in the last 2 slides are listed there for you, and then a simple yes/no. Do I get strep coverage or not? So the benefit is from just about all of our agents, we are going to get strep coverage. So nafcillin, cefazolin, clindamycin, dicloxacillin, cephalexin, all of those we're going to get strep coverage from. In addition, we're also going to be able to get strep coverage from vancomycin, linezolid, and daptomycin. So the 2 where we really don't get any strep coverage are doxycycline and Bactrim. And Bactrim is sort of a debated antibiotic in terms of whether or not you get strep coverage. But I think if you polled our ID physicians, the majority of them would tell you that we do not get strep coverage from Bactrim. So I think that's important to point out, and just an important consideration when we're thinking about the location of the cellulitis and which microbes our patient is most at risk for, since most of the time we're not getting cultures. We've already talked about how cultures are not beneficial. So hopefully this slide will help you in terms of thinking about, am I able to get staph and strep coverage? Since those are predominantly the 2 bacteria we're looking to cover in a patient who has cellulitis. So I wanted to share with you a study that was recently published in 2013 that takes a look at, should we be adding MRSA coverage to our general strep MSSA coverage? So it's a study that took a look at using Keflex or Cephalexin plus or minus Trimethoprim Sulfamethoxazole. And so this was a randomized, multi-center, double-blind, placebo-controlled trial, and they enrolled patients who had cellulitis but did not have an abscess. They had symptoms for less than 1 week. They didn't have diabetes, immunosuppression, or peripheral vascular disease, and they were not hospitalized. So these are outpatient, relatively healthy folks who were admitted into this trial. They had 146 patients that were enrolled. In terms of the baseline patient characteristics, they were predominantly Caucasian. 60% of the patients were Caucasian. And they were relatively young patients with a median age of 69. And about a third of the patients were participating in sports, since we know we've seen several MRSA outbreaks in patients who play sports. So their main outcome that they were looking at was clinical cure. And their clinical cure was essentially defined as a resolution of symptoms with only slight residual erythema or edema. And the clinical cure was determined by an in-person examination at about 12 days, plus or minus 2 days, by an emergency department physician. So let's take a quick look at what they found here. So in the left-hand column, you see the total participants with various outcomes. Clinical cure, which is their main outcome, is in that first row, followed by various additional outcomes, so progression to abscess, and then any adverse event with the different adverse events listed below. The next column is the patients who received both Cephalexin and Trimethoprim Sulfamethoxazole, which was a total of 73 patients. The following column is the folks who just received Cephalexin with placebo, what their outcomes were. Then you see the risk difference in the next column, and then the p-value comparing the two. So in terms of cure, about 80% of patients in both the patients who received Cephalexin plus Trimethoprim Sulfamethoxazole, and about 80% who received only Cephalexin. And the difference was only about a percentage of 2.7% or almost 3% that were cured to a greater extent when they received combination therapy compared to only the monotherapy. And this difference was not significant. In terms of the adverse events, you can see that actually diarrhea was more common in people who received monotherapy, and most of the side effects that are listed are mild, some GI types of things. Rash was more common in patients who received dual therapy as well as pruritus, but really no significant differences in terms of the adverse events that they saw in these patients. And so essentially, the take-home point is that in these relatively healthy patients who don't have an abscess, who present with cellulitis, there's not any benefit in terms of adding trimethoprim sulfamethoxazole. So I think, we've talked about epidemiology, and yes, it looks like there's more community-acquired MRSA that's creeping up in terms of our cellulitis infections, but there's no benefit to giving them Bactrim just off the bat, especially when we look at our progression to abscess and our clinical cure rates. So I have a couple more studies that I want to take a look at that have come out, and I think they address some, more controversial topics in this arena. So the next thing that I think has come up in terms of a debate is when we're looking to get community-acquired MRSA coverage, should we use Clindamycin or should we use Trimethoprim Sulfamethoxazole? And I think the big difference between these two, at least the difference that I've seen most cited, is that with the Clindamycin, we're still going to maintain our strep coverage. With the Trimethoprim Sulfamethoxazole, it's likely that we're going to lose our coverage. So this was actually a study that was I haven't seen it come out in article form, but the abstract is available from the 2013 ICAC meeting. And essentially this was a randomized multi-center trial comparing patients who received clindamycin to trimethoprim sulfamethoxazole. So eligible patients had skin infection, abscess plus minus abscess and or cellulitis. They could not be systemically ill, diabetic, or require hospitalization. So again, we're talking about people who are not sick enough to go to the hospital. So trying to present some data that can be really helpful for those of you practicing in the community. If there was an abscess present, they did receive drainage, which we know is incredibly important for source control. If somebody has an abscess and it's not drained, it's very difficult to clear up that infection only with antibiotics, simply because it's just very difficult for antibiotics to penetrate into that abscess. So patients were randomized to either clindamycin 300 milligrams 3 times a day, or trimethoprim sulfamethoxazole, 1 double-strength tablet twice a day. They were treated for 10 days. They were also given a placebo control. So in terms of talking about the study participants, a total of 524 patients at 4 different sites in the United States were enrolled. They had a mean age of 27. So again, we're talking about a younger group of patients. 45%, so almost half of them, had some sort of purulent drainage, kind of leading us to think that they had potentially methicillin-resistant Staph aureus. As we know that the MRSA, as we sort of talked about, has that genetic difference than our hospital-acquired MRSA, making it more likely to cause purulence and to cause abscess. And the majority of patients actually did have an incision and drainage as part of their management. There were cultures done in about 42% of the patients. 80% of them grew Staph aureus, and of those who grew Staph aureus, 14% had resistance to Clindamycin. So just to point that out. So their major outcome was clinical cure, defined essentially the same way as the previous study. And they were looking at clinical cure achieved 14 days after they were enrolled. So the clinical cure in both groups was about 80%. So very similar in terms of the clinical cure. In terms of adverse events, diarrhea was more common in the Clindamycin arm, which is not surprising at all. There were no cases of Clostridium difficile diarrhea and no severe rashes in the Trimethoprim Sulfamethoxazole group. So essentially, what this study proved is that really they're pretty much the same in terms of their clinical cure and in terms of their tolerability profile. So we've sort of already talked about pros and cons of these two agents, but just to sort of wrap it up so you essentially have this clinical pearl to walk out of here with is Clindamycin is very good to treat strep, and it's active against most Staph aureus, including MRSA. And then really, the big side effect with Clinda is certainly the diarrhea and GI intolerance. So the benefits in terms of Trimethoprim Sulfamethoxazole, it gets great Staph aureus coverage, but we've already talked about the strep coverage. Probably, is debatable, but really you lose the strep coverage when you use Trimethoprim Sulfamethoxazole. And the severe reactions associated with Trimethoprim Sulfamethoxazole include severe rashes and hypersensitivity reactions, but those are relatively rare. So that sort of in a nutshell tells you they're really the same in terms of their ability to treat these types of infections in these ambulatory patients. And from a side effect profile, they're generally both very well tolerated. So hopefully that helps in terms of taking something back to practice. So in this study, there was a lot of grumbling about the Bactrim dose. So the last thing that I wanted to just cover as part of our clinical controversy and maybe some controversies that are out there in terms of determining how to best treat patients with cellulitis is the question of Trimethoprim Sulfamethoxazole dosing. Should we be using one tablet or two? And actually the study that I'm going to discuss here was a study that was published in 2011. And specifically, this study looked to investigate whether treatment with a higher dose of Trimethoprim Sulfamethoxazole led to greater clinical resolution in patients with SSTIs caused by MRSA. So this study that I'm going to tell you about is a prospective observational cohort with a nested case control study that was performed in Texas. So patients who were admitted during the time period that they were looking at who had an MRSA SSTI and received oral monotherapy with Trimethoprim Sulfamethoxazole and whose clinical outcome was known were included, and they compared those who got the higher dose to those who got the standard dose, and they were treated for between 7 and 15 days. The slide that I have listed up here for you shows you the demographic information. So the clinical parameter is listed on the far left-hand column. The next item that you'll see are two columns. These were the results in terms of the number of patients who were treated with Trimethoprim Sulfamethoxazole twice daily. So the first column that you see are the patients who were treated with one double-strength tablet twice a day. The next column is the patients who were treated with two double-strength tablets twice a day. The next item that you see is the odds ratio, followed by the confidence interval and the p-value. So to tell you a little bit about this patient population, the median age was a little bit older than the two studies we just talked about, with a median age of around 40 in both groups. The number of patients in each group that was female was slightly higher in the lower dose group, around 50%, about 40% in the higher dose group, but this difference is not statistically significant. In terms of the median body weight in both groups, it was slightly lower in the lower group, with that being 77 kilos as the median weight, but with a range of 44 to 156 kilos. So a pretty big range, pretty comparable to what you see in the high dose group, where the median weight was 86 kilos with a range of between 42 and 141. Again, these are not statistically significant. The same thing is true with the body mass index. So the average body mass index is right around 30 for both groups, and the difference was not statistically significant. If you take a look, the next items that are included are the different disease states that were, or comorbidities present in each of the patients. These are relatively similar between the groups, just to highlight the things that are statistically significant in terms of differences. The number with a history of trauma on admission was higher in the higher dose group, but they were very small numbers, only 4 patients in the low dose group and 9 patients in the high dose group. The other item that was different is the receipt of incision and drainage was actually higher in percentage-wise in the group that got the higher dose than it was in the group that got the lower dose. So more patients received an incision and drainage in the higher dose group, maybe leading you to think that this group was a bit more sick. So then taking a look at our outcomes, because that's really what we care about. So the last 2 rows are the median treatment duration and then the number of patients with clinical resolution. So the median duration was similar between the 2 groups, about 10 days with a range of between 7 and 13 days. Not statistically significant between the groups. In terms of clinical cure, and really probably what's most important is the percentage, because there were more patients who received the lower dose than the higher dose. Total of 170 patients in the low dose group and 121 in the high dose group. You can see that in both groups the clinical cure is right around 70%. So not statistically different. You might say, well, were the patients who received the higher dose sicker because there was more incision and drainage? But the authors astutely noticed that and did adjust for incision and drainage, and again, there was no difference in the patients with clinical resolution. So in terms of 1 tablet versus 2, from a clinical standpoint in terms of resolution of disease, based on this study, it appears that there is no difference. So the other thing I think we have to think about are what are the consequences of using the higher doses of trimethoprim sulfamethoxazole. So in this particular study, adverse drug reactions were seen in 9.1% of patients. 13% of the patients in the high dose group developed an adverse drug reaction, whereas only 5% of patients in the standard dose group developed an adverse drug reaction. And the most common adverse drug reactions, not surprisingly, were hyperkalemia, acute renal injury, and rash. So when I take a look at this study, I really think to myself, to me it looks like, based on this study, there really is no difference between using the standard dose and using the higher dose. And we're having an increased number of adverse drug reactions in the higher dose group. So to me, this shows that the standard dose regimen is likely adequate, that more drug doesn't mean better outcomes, at least from this one particular study. Okay, so those are sort of the 3 clinical controversies that I wanted to address that they don't really go over in the guidelines, and I think are things that may come up in your practice. And at this point, it's time for the second of our 2 poll questions. So it's back to our patient case. So to remind you, we've got our 35-year-old male who's got a fever. His primary care physician has decided he's got cellulitis and has opted to treat him as an outpatient. And the reason is, so Cephalexin is a fabulous choice, but certainly it doesn't cover methicillin-resistant Staphylococcus aureus. Then thinking about our combination therapy groups, trimethoprim sulfamethoxazole does cover MRSA, but we lose some of our strep coverage, but certainly we gain that back with our Cephalexin. And the combination of the Cephalexin and Clindamycin, now we've got really great strep coverage, MSSA coverage, and MRSA coverage. So we've got, for sure, everything covered with our first 3 regimens. And so I think the best answer to this question is actually D, the monotherapy, the Cephalexin 500 milligrams orally every 6 hours. And the reason is, so none of these are wrong, but, medicine is frequently a bit gray. And the reason that I think this is the best answer is because my question was, would best treat his cellulitis and minimize his likelihood of experiencing adverse events. So we took a look at some different studies today, and we certainly know that we saw the study where they compared healthy patients who received Cephalexin monotherapy to those who received Cephalexin plus trimethoprim sulfamethoxazole, and the cure rates were essentially the same between the two groups. So this is a patient who's presenting. He doesn't have any sort of abscess. We know that an abscess is likely more common with an MRSA infection because of the genetic differences that we talked about. He doesn't have an abscess. He's very healthy. So it's not that he doesn't have MRSA. I think we're pretty safe going with a therapy where we don't necessarily include MRSA coverage, especially taking a look at that study. And then just comparing A and B, the difference is really 1 double-strength Bactrim tablet every 12 hours to 2 double-strength Bactrim tablets every 12 hours. We took a look at that study again in outpatients, relatively healthy patients, this time now with abscesses, that compared the 2 dosing strategies. And again, there was really not much of a difference in cure rates, but there was an increased risk of adverse events. And so anytime you increase the number of medications that you're on, certainly you're increasing adverse events. And then C, our third choice, again, clindamycin, now you're adding in the potential for GI toxicity associated with it. And when you took a look at clindamycin regimens compared to trimethoprim sulfamethoxazole, Bactrim generally is better tolerated than clindamycin. And I would say in combination, we typically see Cephalexin with Bactrim, mainly because people are concerned that they lose that strep activity with the Bactrim, but feel that the Bactrim will be better tolerated than the clindamycin. And with the Cephalexin and the clindamycin, we then have the overlap in terms of strep coverage. So as I mentioned, none of these would be wrong, but I think the best answer to best treat his cellulitis and minimize toxicities is going to be monotherapy with the Cephalexin 500 milligrams every 6 hours. So I want to just wrap up by telling you the treatment duration. You might have already guessed based on the studies we've talked about. In uncomplicated cellulitis, generally 5 days is the minimum. If it's more complicated, takes longer to really clear up. Likely you're going to go 10 to 14 days, but it could be longer depending on the response. There's really no magic number, but certainly if you can treat somebody for less time, they appear like their symptoms are resolving faster. Certainly, I think less is more in this case in terms of predisposing your patient to get Clostridium difficile diarrhea or some other drug-resistant pathogen. The last thing that I want to talk about before we go over our summary of our talk today is a new medication that came on the market in 2010. And I want you to know that I have no ties to the company that produces Teflarom or Ceftaroline, but because it's not included in the guidelines, I think it's important for you to know about this drug. Because it came on the market in October 2010, and our last update for these guidelines was in 2005. So Ceftaroline or Teflarom is indicated in acute bacterial skin and skin structure infections, so SSTIs, as well as community-acquired pneumonia. So I think we did mention this when we talked about our pneumonia discussion. The dose is 600 milligrams. It's only available intravenously. It's every 12 hours, and it does require adjustments in renal dysfunction. It is a bactericidal agent with time-dependent killing. And it's a prodrug, so it's rapidly metabolized to the active drug in the blood. In terms of the spectrum of action, it's very similar to ceftriaxone, but now we're also getting MRSA coverage, which is sort of the benefit of it. So you're getting strep and staph coverage. A couple things to note: it's not active against atypical pathogens such as Mycoplasma pneumoniae as well as Chlamydophila pneumoniae. And so if you're thinking about treating someone with CAP with Ceftaroline, you'd need to add on a macrolide such as azithromycin. It's also important to note that it's inactive against organisms that produce AMP-C, beta-lactamases, and ESBL. So when you start to get some of those multi-drug resistant gram-negative organisms, it's not going to cover those. It also doesn't cover Acinetobacter. So not a great agent if you've got something gram-negative that's fairly resistant. But it is another option for MRSA. And when they took the 2 trials that looked at the treatment of cellulitis were Canvas 1 and 2, it was compared to vancomycin in these trials, and it was proven to be non-inferior. So it is another potential option for somebody who has a skin and soft tissue infection in addition to the other agents that we discussed. It is more expensive compared to vancomycin, and I think also compared to clindamycin, so you might want to reserve it for somebody who's had a treatment failure with something that's a little less expensive. Okay, so that wraps up our discussion of cellulitis. Just to sort of summarize some of the key points that we've talked about today, the majority of skin and soft tissue infections are caused by gram-positive pathogens, with Staph aureus and Group A strep being the most common. There are some controversial issues in the management of SSTIs that we've discussed. So specifically, we've talked about which agents we are able to get strep coverage with, whether or not we need to cover for both get really good strep coverage as well as cover for MRSA in our outpatient population. And then finally, whether or not Clindamycin or Trimethoprim Sulfamethoxazole are better as initial therapy in our outpatient population. So now hopefully you've got some good data and some good answers to take away from this talk today to answer those clinical controversies. And then finally, our antibiotic duration really needs to be guided by our response to therapy. We certainly want to limit the course to as short a course as possible. So I thank everybody for tuning in today, and at this point in time, I'd be happy to take any questions.